remove the offending electronics. We have a real computer. This is an Apple. I don't know what it is. Hope he comes back. Anyway, today we're going to have some fun. Some of us, maybe not all of us. I will. I know that. I suppose you all are wondering about so-called image challenges, and we'll have 2 or 3 of these or more throughout. This is your chance to shine, to look good. Okay? Everybody looks. Y'all don't look happy. She doesn't look. Oh, no, don't. No worries. This will be fun for the people that are here, and not fun for this side of the room over here where no one's here. So, you haven't missed anything. We had some technical difficulties. Anyway, so here's what this is. Let me figure out how to use this thing. There we go. Called the Image Challenge, and this is your chance to, we're going to be looking at images, and you're going to be analyzing them all by yourselves without my help much. I'll give you a lot of help. But what you try to do when you look at an image is these things. This is what should be going through your mind when you're standing and maybe shadowing a radiologist or a nuclear medicine person. You ask yourself some questions and answer them even before you start thinking about what's wrong with the image. And that's what very first thing is. What's the modality? By modality, I mean, what are they using? Is it CT, plain radiography? Is it nuclear medicine, ultrasound, MRI? Got to know what you're looking at to be able to interpret the image. Second thing you do once you've decided what the modality is what body region are you looking at? You're looking at the head, you're looking at the chest, the abdomen, pelvis, extremities, and that's sometimes harder than you might think. Is there contrast material present? Okay, we have contrast. You've seen contrast for x-rays, right? You seen that. They have it for MRI, and even ultrasound has contrast. Anybody know how you do contrast for ultrasound? Micro bubbles? Yeah, teeny tiny bubbles. You inject them into a vein, and that's an acoustic contrast agent. And then you look at, you try to put it all together, and you look at, are there any asymmetries in what you see? Is the right side a little different from the left? And that can help you a lot decide what's going on in the image. And then, if you know you're looking at a chest, for example, is there a sternum? Are there ribs? Are there lungs? Are there heart? Are these things there or not? And finally, do they look normal? Okay. Are there any processes going on that you think might be happening? So, and then you put it all together. Okay. So, let's get started. Okay, let's see. Who's going to be my first victim? This is going to be a fun one. Everybody has, the trick is you got to stand up here. But you can't do this from your seats. I'm going to turn the lights out. Okay, now, so what's the modality? She's going to demonstrate the right way to do it. What's the modality?
X-ray?
Yes, a plain radiograph.
Looks to be like the lower extremity.
Yeah, it's the lower part of this person's body.
Yeah.
It's the pelvis and lower extremities, you could say.
Yeah.
Okay, contrast? No, there's no contrast here, just bones and soft tissue.
Okay. And then
No,
is everything there? I don't know, the tailbone seems to be a little bit too extended. But it's just me.
Think about what you know about the anatomy of the human spinal column.
Yeah.
Seems to be a little long.
Yeah.
Yeah, a little long.
Yes.
Because this is not a human spinal column.
Yeah.
Yeah. This is
It's
a dog's tail.
Yeah.
What the cops did, they suspected a doctor of, and this is important in news today, is the opiate addiction crisis. No, this is in part fueled by people who wanted to make a big bunch of money, and doctors like making big bunches of money, and this is an easy way to do it. That's to prescribe tons and tons of opiates, okay, to people who really didn't need them for pain control. And the police suspected this doctor of doing that, and so they did this so-called sting operation, where they had a cop go in and complain of pain, and gave the doctor her x-rays, and he put them up on a light box and said, oh yeah, here, 30 hydrocodones or whatever, Darvocet or whatever, without even, and they caught him that way, because that's obviously not her x-ray, right? So, x-ray of a dog. They grabbed somebody's dog and did it. Okay, now, very good, that was, that's how it's done. All right, now you gotta do it for real. Okay, and we might go by alphabetical order. Mr. Chen, Mengkun. Oh, there he is. Come on up. Step on up. And he's going to stand. I think the best place to stand is right about where Grace was standing, right here. Maybe a little back even. This is a little much. Okay, here's your. This is just to orient you. This is a normal chest X-ray. We've seen it before, with this you can see the. So you got, your costophrenic angles are sharp here. You see the trachea is in midline. That's important because what happens if there's a mass in the chest, the trachea will get deviated. So it's pretty much in midline. And the lungs look clear here on this. So normal chest film. Now here's yours. First, tell me the modality.
This is my lung.
Radiograph of the chest, right?
Yeah.
Okay. This is kind of a trick question. Is there contrast material here?
The veins.
Are those veins, do you think? So is there contrast? That's the question. Yes or no?
Yes.
Okay, there is contrast. It's kind of a trick question. That contrast, if you look, it's we sometimes give people oral contrast by mouth to look at the stomach and the gastrointestinal tract and the esophagus. This is not, and this is what happened with this patient. This is contrast. But what happened was the patient aspirated the contrast unintentionally. In other words, breathed it in. Okay, took a big gulp and like that, and it all went down the wrong way. It's called aspiration. And so yes, there's contrast here, but it's not where it should be. And inhaling this much contrast, this is a very thick barium slurry into your lungs, doesn't have a good outcome. Usually, the best thing that can happen to you get a chemical and infectious pneumonia or die. I think probably what happened here. So, yeah. Okay. So there is contrast. This contrast not where it's supposed to be in this case. You remember that plastic cast of the bronchial tree? This is this. And this stuff just concretes in there. It just dries up. It's awful. Okay, good. Thank you. All right. Who is next? Ooh, Miss Troniak. She looks thrilled. Come on, this is fun. Yes, fun for me.
Okay, so we have two. One is CT, one is radiography.
Yeah, there's two modalities. There is a plain radiograph on the left and in the same patient, a CT scan of chest. Okay, so is there a contrast in either one of these? How about the radiograph? Is there a contrast been given?
I don't think so.
No. How about the CT?
That's the one I'm not sure about. It kind of thinks there is contrast.
Yeah, there's contrast. The way you can tell is that the brightest things in here are the blood vessels and the ventricles and the heart in this transverse section. Okay, so they gave contrast here for whatever reason. Now, so kind of, we've seen some lungs, okay, and does this look okay? Either in the chest radiograph or the CT scan? Usually in the, let me go low tech here, get a point around. Usually we see nice lung markings like this, right? And on a CT, it will look a little like this as well over in these areas. But we have areas in this which is kind of, they would refer to this as patchy opacification. Okay, it's not as transparent as the lung should be. Okay, so, and the same over here. You see here what are called air bronchograms. These are, it's kind of air is acting as a contrast here. And you can really see the bronchial tree against all this, whatever this is in here. And we'll see some more air bronchograms maybe a little later on. So you would say this is normal or not?
Probably.
No, it's not normal. This is a child, this is 10-year-old. This is a consequence of things that are going on in this particular instance was going on in Iraq, in the Middle East back in 20 years ago. It's called barotrauma. It is from blast pressure in the chest has collapsed the lungs here. So both his lungs are collapsed because of the force pressure of the explosion. What they call a barotrauma. Okay, and obviously you're gonna have all that trouble breathing. So this person, you see this here, this little thingy here, this is a tracheostomy tube where you can hook people up to a ventilator and be able to assist them in breathing. Okay. So, and you can see on this chest radiograph, they usually make the tracheostomy tube have a radio-opaque band in it so you can tell where it is. That's what that is. And you can see it actually, I don't know if you can see it here or not, but anyway, that's what we have here. Good, thank you.
So the person has to live like this for the rest of their lives, or how do they fix it?
They can slowly reinflate the lungs gently by gradually increasing the pressure. It's not a good prognosis, though. We'll see. Okay, very good. Who is next? Miss Queen. You can't escape me. Next time, she will be first in line.
Is that QI?
Mr. Dang,
Oh, excuse me, was that
did I
QI?
say your name all messed up yet?
Oh, is that
Let me
QI?
ask you. Meng Chuan.
Oh, no, that's
See.
not.
See? Okay. Mr. Dang. Who's next? How about our friend, Mr. Facina? Occasionally comes to class. Rarely. You don't think I know who's not here? Where's Mr. Good?
He's not here.
He's not here.
No, he does.
He's always here.
He's always come.
Okay. Mr. Hoopenlanger.
Garner?
Oh, he's not next. Ooh, Mr. Holden. Sorry, almost skipped you. He said, that's okay. All right.
It's a chest radiograph. Looks like they have a lesion in the right middle lobe.
Yeah. Remember the right lung has 3 lobes? Some of you didn't know that on the exam, but it does. Left lung has 2. Right lung, upper, middle, and lower down here. And like Mr. Holden says, this is some lesion. Don't know what it is yet. So moving on to
These are
These two,
CTs,
yeah.
and
What kind of section is this?
this is a coronal.
Yeah, coronal, reconstructed coronal. The data was acquired transaxially. Believe it or not, you can actually do some CT scans directly coronal.
Oh.
You gotta twist people around the scanner a little bit, but you can do it. Okay.
And then I think I see all the structures they should see. But that's the mass right there. It looks like it has arterial supply, but I guess I would guess it's some type of cancer.
Well, it has an arterial supply right off the aorta. So
So
descending aorta. Very few things that actually happens.
right.
So it's anomalous. This has contrast, so it's descending aorta here. So it has an anomalous arterial supply to whatever this is. And if you look over on this one, this has venous supply that goes directly into the pulmonary artery. So
Oh. Yeah.
this is called a pulmonary sequestration. Pulmonary sequestration is congenital. It is just what happens is that this really doesn't have a connection with the rest of the bronchial tree. Okay, so it's got abnormal arterial and supply and a venous return, and it doesn't have any communication with the rest of the trachea or the rest of the bronchial tree. So it's just, an abnormality of fetal development, which the problem, because it doesn't have that bronchial drainage, these things get infected. That's what happened here. So that's why the kid came in with a high fever and they did this chest x-ray. They knew it was there. Okay, that had been established a long time ago. But it didn't bother anybody, so they left it alone until it got infected.
Does it regress over time, or does it stay?
Not really. It just sits there, usually doesn't do anything, and usually, most people wouldn't know they had it.
I didn't even know that was. Okay.
Okay, good, thanks. All right, Mr. Hoopenwinger.
Garner.
Sorry about that.
It's okay.
I do know a Hoopenwinger, and you're not him. Hoopenwinger. Scott. Okay. Your turn. We'll start with this one.
Radiograph.
What part of the body?
The
Chest.
thorax,
Yeah.
chest, yeah.
Thorax, chest, yeah.
And then we have CT for B. And that looks like MRI.
It is.
Yeah.
So you got all three modalities that we've been talking about here. Chest radiograph, going in order of cost, $80, $300, $800. Okay. And you get all three, add it up, and you get your medical bill. So this is, this is German, these arrows here, the German word is Hirschmutz. This means something going on here. And it's where somebody gets marked, something on a radiograph, get your attention. So we got some big arrows here pointing for why do you think they're pointed to that area of the chest?
That's where the B lesion is located, or?
Well, this is called a widened mediastinum. Mediastinum is that area of the chest where the esophagus, heart. Remember, that's going to be on your qualifier for you med students, medical physics people. Mediastinum, this is wide mediastinum. Usually indicative of some kind of mass in the mediastinum. And indeed, got the same arrows here. Okay, so you got a mass in there. And, you can't tell whether this is posterior or anterior, right? Unless you get a lateral radiograph, which they're not showing you. But instead of spending another $40 to get a lateral, why don't we just go to the $300 study instead? And so we can do that. And we see where the mass is. Okay? So, and we see that this mass is doing what? We got this black arrow next to it. This mass is eroding into the bone on this vertebral body. And then on the MRI, you can see the mass down in here. But this is the most spectacular one that you see here. It's pretty obvious. Is this, there's what we call a differential diagnosis. This could be a malignant tumor that is invading bone, but it is not in this particular case. But I wouldn't know that until I stick a needle into this thing and pull it out, and I do some staining on it, and I find a whole bunch of what are called mycobacteria, bacteria that causes tuberculosis. And this is one of the complications of long-standing tuberculosis is what's called, in the old days, they called it Pott's disease, P-O-T-T-S, after some guy who described it, Pott's disease. And this tuberculosis eroding bone is what that is. Okay, good, thank you. All right. Jordan, Corey. Where are all your colleagues today?
I don't know. I just texted them. Good question.
It's not your day to watch them. Okay. All right. But Mr. Huber is here. Nice to see him.
Looks like the standard chest radiograph on the left, and then CT on the right, transverse.
This is the same patient, it's just different transaxial sections, which you will identify in a minute. Okay, so we got chest radiograph and 2 chest CTs. Is there contrast?
I don't think so.
That's correct, there's no contrast. And again, you have little arrows, German Hirschmutz, here's something bad. Pointing to, what are they pointing to? They're pointing to an area of increased density that is, I don't know, correlates with these areas of increased density on your CT scan. So what is that? What structure?
Got the aorta.
Yes. What part of the aorta on this section?
That's the aortic arch.
That's the aortic arch. On this section,
Descending aorta? Or is that going into?
you're going down a little bit, or up a little bit rather. No, down, inferior, okay, because, so you have your ascending and descending aorta here.
Okay, yeah.
So there's no contrast, so what is this? Look at the density. If you were to get your computer out and look at the Hounsfield number here, that's indication of the density. It'd be about the same as bone. Okay. Do we have bone in our aortic arch? Did I talk about the bone of the aortic arch and the musculoskeletal part? No, I did not. So this is a process that overall is called calcification. Something accumulates a substance containing lots and lots of calcium. So this is a calcified aorta. Usually what happens in a process called inflammation, which we will talk more about when we get to the immune system, the body's inflammatory reactions to certain things that are going on. If it's long-standing, one of the results is calcification of a structure. And so that's what this is. This lady had long-standing inflammatory disease, usually just of the blood vessel linings, and it's usually just like lots and lots of plaques, okay, cardiovascular plaques. And she's probably got this all over her body, actually. So that's what this is, calcification of the aorta. The colloquial term for this is a porcelain aorta. You know, porcelain is a stuff they make, dishware and cups and stuff. Porcelain aorta. It's very brittle. This thing is, not real stable in this condition. Okay, good, thank you. All right. Mr. Johnson.
Okay, so conventional radiograph.
What?
Oh, there's no.
Remember I should, one of the things we focus on early on in a chest radiograph interpretation is the trachea. Okay. So trachea is this midline, low density structure here. And it is midline. That means two things. Either there's no mass or anything like a pneumothorax or a mass moving the trachea over. Sometimes the trachea can also be not midline because the patient's like a little like this. That can fool you. Okay, so this is a straight on, nicely done anterior, posterior anterior chest radiograph. Okay, so what's going on with this trachea? Okay, so it's going down into the lungs, and so it gets lost in here, but trachea going up. And what does it look like? The most superior portions of what you can see. What is happening to it?
It seems torn.
No. Containing air, so, and it's getting narrower. A trachea is getting narrower. This airspace is getting narrow until finally, you don't see almost no airspace at all. And this patient, this chest X-ray looks huge. That's because they've taken a fairly small chest X-ray and blown it up. And the reason you have small chest X-rays and people that have their heads down like this and can't cooperate is a kid. It's a little kid. He's maybe 3 years old or 2 or 3. Back in the old days, people died of this disease. This is, they call this a steeple trachea. Okay, this steeple sign is where it gets narrower and like a church steeple going up like this and finally narrow. Diphtheria. Tons and tons of kids before immunization. I've had some distant relatives and back in my family tree just died at age 10 of diphtheria epidemic. So what happens, you just can't breathe. And you get this extremely high pitched breathing and then you stop breathing and then you die. So this person would probably have to be intubated, have to put a tube down into the trachea to open it up and let air in. Okay, good, all right. Wesley, Kendall, I always see in the very back corner. Good place to sit. All right. Let's see. New.
The CT.
Yeah, so CT scan of what?
Just the lower in the body.
Huh?
Lower, like.
Nope. Well, we're like, didn't they take biology in high school? You know what? Insects have 3 body parts, head, thorax, and abdomen. We have the same 3 body parts, head,
Okay.
thorax, and abdomen. So what you would look at this and say, well, this is, normally, the only place in my body or y'all's body that you have all this air is in your thorax, so,
Okay.
or chest.
Okay,
So
so chest.
you say, okay, this is
Chest.
chest CT.
Okay.
Yeah. You've seen some chest CTs. This is air. This is a normal window. Okay, so the air looks not dense. Bone looks dense.
Yeah.
Is there contrast? Have we injected contrast?
I don't think so.
Yeah, we have. Okay, so yeah, there's contrast. These are major blood vessels. Okay, the way you can tell is you look at your aortic arch, if you can see it, or the ascending and descending portions of the aorta, and here's soft tissue. Blood and soft tissue should be about the same density on a CT scan, but they're not. This is a little brighter. It means it's been opacified. And you can certainly see some very large, these are pulmonary arteries. They're huge, okay, in this particular patient. Big pulmonary arteries. what else might strike you abnormal? And this is something that radiologists always do so you're focusing on maybe a heart-lung problem, but you got to look at everything else. And so what they start out with often is looking at the bones. So what's going on? The bones here. Remember, we see ribs and things like that, and on a CT scan you can see the marrow inside the ribs, a little bit of marrow, a little strip. But here's your scapula. This got in a large narrow space. All the ribs here, the ribs are huge, bulging out with bone marrow.
Mhm.
So, to make a long story short, as they say, this is a person who has a particular kind of anemia. Okay, it is congenital. It's like sickle cell anemia in its consequences, but it has a very different origin. It's called beta thalassemia. Instead of in sickle cell anemia, you have one amino acid replacing another in the whole hemoglobin molecule, and it makes your cells crenate or sickle. In this particular case, the genetic defect is introducing a alteration in a base pair that makes the codon called a stop codon. Okay, so one of the particular triplets that tells the DNA polymerase to stop doing something, stop making a protein. And that's bad news, because if you do that with hemoglobin, you don't make any hemoglobin, it's normal. So it's the beta chain that is not synthesized in this particular case. So you don't have functional hemoglobin. So what the person has to do is in response, the body tries to make more and more and more blood cells. And so it expands the marrow to produce more and more blood, or try to. That's what this is, because marrow expansion is the term they use. So beta thalassemia, you're born with it, often gets diagnosed early on in infancy. People, they have a kind of a facies because of that expansion of marrow everywhere in the body. When you're a child, a lot of your bone marrow is in your face, actually, and so that gets expanded. But actually, they don't look bad at all. It's actually kind of pleasant looking or nice looking. But you've got all this going on. So difficult to treat. You need a lot of blood transfusions. And so what happens, you get a lot of blood transfusions, you get what's called iron overload eventually, and your liver stops working. Not good. Most people don't live past their 30s with this. Okay, thanks. All right. Lay, lam. Sorry. Lay, lam. There you are. Good. Okay, let's see what we have for you. Oh, no, this is mean. I'm not particularly being mean to you, but it's just mean.
Maybe I'm not.
Maybe, huh? Maybe I should go on to I'll give you something else. This is on, even people like me miss this. Okay, so, but chest radiograph, right? Okay. If you look, we look for asymmetries. Okay, and so you have a lot of lung markings here. Okay, that are normal, here and down here. If you look, you can follow pulmonary artery branches all the way out. Okay, here's one starts out. You can see it threading up here. There's others that you can see here. It's very subtle. But in this area of the lung here, you don't see that in this little area right here, this asymmetry. So, and if you look closely, here's a branch of the pulmonary artery that's cut off right here. And this is called something, I have a name for it, like everything else in radiology. It's called Westermarck sign. And it's just a lack of normal lung markings in a particular area on a chest radiograph, and it means that the blood supply here has been cut off. So you remember the name for that? When you have a blood clot in the lung that pulmonary embolism. Yeah, that's fine. Pulmonary embolism. Okay, that's what this is. Not a huge one like some of the ones we've seen, but yeah, that's what this is. Okay, now yours. You get to do this. I will tell you that this is normal. These are not the same patient. These are different patients. This is a normal what? Yeah. This is, because you have your pelvis here, here's your sacrum. This is the lumbar vertebral bodies, 5 of them. L5, L4, L3, L2, and L1's up in here. So this is a lateral projection from the side of the lumbar spine. So it's a lumbar spine radiograph. They may do one with the film back here and the beam coming this way, so it's an AP projection. We don't have that here. So this is normal. This is not. So what, I'm going to tell you that these are actually, the exposure is the same. This is not an underexposed film. Okay, there are normal exposures in both of them. Okay, so what's different about these two? Yeah, okay, so, yeah, more dense. Okay, the x-rays are not penetrating, so that means it's more dense. So the other thing that you see is they're not more dense all the way. You see this stripe right in here. Anybody play rugby? Rugby players wear a particular striped jersey. Their upper garment that they wear has a big colored stripe. So this is called the rugby stripe sign. Okay, rugby jersey sign. What this is increase in density in the bones from, it could be a lot of reasons, but in this particular guy, this is a guy who drank tons and tons of alcohol. So he decided one day, I'm not going to drink any more alcohol. So after he got over the delirium tremens and everything else, DTs, he substituted his alcohol for mineral water. This is in France, where the mineral water from where he was had a very high fluoride content. So he had plenty of intake of fluorine, sodium fluoride. Okay, well, so it made his bones dense. So do you think that made his bones strong and hard? Just made them denser. Actually, the bones in fluoridosis, what's this called? They're more brittle. They break easier.
Yeah.
Okay, so if you're going to stop drinking, don't drink a whole bunch of mineral water. That's take home lesson. Thank you. Okay.
No, but you can sit there.
Let's see. You know, coming in late doesn't always let you avoid pain, Mr. Hoory.
That's not great.
That's not me.
It's not you, Hoover.
No,
I'm Schaefer.
you're not there.
Oh, I haven't gotten that far in the alphabet.
Yeah.
Oh,
That's
good, thank you. You look just like them. These pictures, nobody looks like their pictures.
You look like
Nobody.
mine.
Nobody. Grace,
I
you look
don't.
like your pictures. But
Sort of.
you're not smiling in your picture. So, okay. Ooh. Ms. Lee, Mukong Lee. Oh, she's, okay. Ooh. Color, finally.
CT scan, the chest part.
CT scan of the chest. You can speak up. You can yell. You see,
The color is like breathe in some gas.
well, this is what we call a fusion image. fusion engine. Remember the PET, CT? Okay, so the colors that you see are the PETs part. And what looks like a CT is the CT. And again, the reason we do this is to be able to figure out the anatomy. Okay, because if I just had the PET part, all I would see is this blob, this blob, this blob, and this blob, and I'm, well, I don't know, where am I? So that's why we invented PET-CT, to have this at the same time, at exactly the same time, this anatomic registration. Okay, so I can tell where these blobs are. So, you see a blob here, and here. I'm going to tell you what it is. PET-CT is done with fluorodeoxyglucose. And you know what, one of the things I told you earlier on, that glucose, FDG, or fluorodeoxyglucose, is a sugar analog. And tumors take up lots of sugar. Okay, so when we first invented FDG, we thought, this is wonderful, this is the magic bullet. Okay, tumors take it up, other tissues not so much. We know there's cancer. Wrong. Okay, we find out years later that what we initially believed is not true. This is not cancer. This is an inflammatory condition that is called sarcoidosis. It's certain people just develop it. It's an autoimmune. We'll talk about autoimmune stuff, later on, but this is an inflammatory process in the lymph nodes, what are called mediastinal lymph nodes in this patient. Now, to be fair, this could be metastatic tumor in these lymph nodes as well. And that's part of the differential diagnosis. You say, well, I don't know. Is it, sarcoidosis, you can easily treat it with steroids. You can't treat metastatic cancer very easily. You need big drugs and radiation therapy. So you want to know the difference. So what they'll do is they'll put a needle in here, get a piece of it, and look at it under a microscope, like we said before, and then they'll know how to treat it. But the PET's useful for that, but in this particular case, not cancer. Good, thank you. Miss Rulin Lee. Very enthusiastic, I can tell.
Alright, the chest X-ray. I didn't see that, okay. I was saying, all those balls in the lung area.
Yeah.
What?
See these? Fortunately, I put the reminder to myself, I left it in the, anyway, I was going to bring the ping pong ball. These are ping pong balls in the lung. Okay. You're not, yeah. Is this somebody who wasn't a very good ping pong player? Hit in the mouth a few times and, no. These are introduced on purpose. Back in the old days, before we had drugs to treat tuberculosis, we did two things. We put people in sanatoriums. There were big facilities where we put people just so the disease would burn out. And they wouldn't, tuberculosis is highly communicable. People spread easily in the population. And so we put people in the sanatoriums, but they'd also do some surgical things to keep big cavities from forming in the lungs and getting more infected. So they did this procedure, it's called plombage. This is the word P-L-O-M-B-A-G-E. Put the equivalent of ping pong balls into the chest, surgically into the chest cavity to keep it from collapsing. So that's what this is. It's called plombage.
What are the wires? The thing on the side of the wires.
This thing here?
No, the side.
Those? Good point. You will see on chest x-rays and things, all sorts of things like that. These are electrodes.
Okay.
For an EKG, you need to monitor this patient. In fact, you can see a tracheostomy tube here. So this patient may not be on a ventilator, but we put tracheostomies in And people just, you know, they just breathe through them. They can't talk because they can't phonate with the trach tube in. So there's all sorts of mechanical devices we can make vibrations that they can phonate, use that to phonate. But, so it's not a very good disease to have, but that's what these are. Okay, good, thank you. All right, here's Lucy Liang. All right. Go ahead, don't be shy. She says it's a chest x-ray. Everybody believe that? Come on, give us some support. Yes, it's a chest radiograph. Looks very similar to one that we saw just a minute ago. Electrodes. Usually when you see electrodes, it means the patient's not doing real well in general. Okay, so something going on. Do you see anything that is unusual that you don't normally see in a chest radiograph? Don't be shy. Okay, you can use terms like to describe it like lateral and upper. Okay, this you're talking about this, right? That's caught your eye. Okay, so it's in the left lung or in the left chest. I don't know if it's in the lung or not. I can't tell in one plane, right? And this is the days before we had CT. So you see this thing in the left, I would just say left upper lobe area of the lung. Okay, so, and the density is not air density, some kind of density almost the same as the soft tissues, maybe a little more. Maybe that's just because there's more of it in this projection. So you got this big thing here, and you know you can see the edge of it. So I guess best way to describe this, it is done for the same reason as the ping pong balls. Tuberculosis patient. So they had a better idea. Instead of the ping pong balls, which very difficult to get out. In fact, they never come out. Okay. Let's do this. Let's take that cavity that we're trying to prevent from collapsing and squirt oil in it. Cooking oil. Put it in there. It's not going to go anywhere because the cavity is all aligned. This is the capsule of the cavity. So you fill it up with oil. Good idea, right? And you leave it in for 2 years. Better idea, right? Leave it in for 2 years, and then you can take a needle, stick it in, and take it out without doing surgery. Pretty cool idea. It's cool, and it's a great idea as long as the person actually comes back after 2 years. This one didn't. Okay, so he had this big thing in there festering for 10, 15 years after it was supposed to be removed. So that caused issues, believe me. Okay, good, thank you. Now everyone is an expert on antiquated means of treating tuberculosis. You know, I say that, but it's only since I've been doing this, anti-tuberculosis drugs are pretty new, actually 30 years ago. So they're very helpful these days. Still a long course of treatment. The patient has to come back to get treatment for 6 months. All right. Who is next? Mr. Yang. Jisham. Yeah, wait a minute. I gave him a little extra time to walk up. So very little. Okay.
This is the emperor with chest,
Yes.
and it looks like the big rectangular white area.
Speak up so they can hear your
the red
description. Yeah.
The big area is abdomen.
It goes all the way down till you lose it into the abdomen. But, you know, you lose it anyway because the liver's sitting here. So yeah, so you have this thing, that, first you look on what you think might be the good side. Okay, and it's the left side. Trachea is midline, that's good. You see pulmonary vessels coming out like this, that's good. Lung markings are normal on this side. If I go over here, tell me about the lung markings over here compared to here. Looking at asymmetries. Are there any lung markings? Normal lung here. You see any pulmonary vessels? Yeah, see, it's empty. It's gone. Here's your right lung. That's your right lung. All collapsed down. This is called your chest is filled with air. Remember, pneumothorax. The chest is filled up with air. You have what is called an air fluid level. This is all fluid in here. So, and that fluid is blood. Okay, this is someone who's been stuck with a knife, not only let all the air into their lungs, but also cut an artery, bled into the chest cavity. It's called a hemopneumothorax. Big word, hemopneumothorax. And you can't breathe with this very well, right? So he has to go in and they'll put a chest tube in here to drain the blood out and then allow air to get in here and reinflict the lung. And so this will reinflict. A few days. Chest tube in. Okay, good. Thank you. All right. And Mr. Liu. Junlan. Liu. Junlan Liu. Did you leave, Junlan? No. Okay, he's not here. You. Jiashu Meng. Yes.
I have a question. Why does it look like the fluid level stops in the spine?
What?
Why does it look like the fluid level stops at the spine? Like it's like what's stopping it from going to the other side of the entire chest cavity?
There is a pleura here, a membrane around the two lungs. Okay, so
Oh, and then it goes all the way down.
that will stop it.
Oh, okay. So then
Okay.
the lungs only goes down.
So because of the pleura, the blood is just confined to the pleura in here, so it's not going to go out of this lung and into this, and it's not going to go in the abdomen either.
Okay.
All of which is good.
Yeah.
You know, you can confine the issue to something you can manage.
That makes sense.
Okay. He's trying to hide. It's very magnified chest. Oh. Actually, let's see. Sometimes it stands, the more back you stand, the easier it is to tell what's going on. In some of these things. Yeah, she said it's a radiograph of the chest. Is that right? Is that what you said? Okay.
And there are some electrodes. There are some electrodes.
The electrodes, yes. Again, an indication that the person is not doing well, is in the hospital. You don't stand in people's way. You can see it also if you have trouble seeing, you can see it on the monitors here. Okay, so got electrodes, got a chest radiograph. We'll say trachea's okay, line, got normal lung markings. So what else do you think is going on here that looks funny?
The vertebra is now straight.
What's that?
The vertebra is now straight. It's,
Well, it's okay.
it's okay.
What is this? Remember on normal chest radiographs, you do not see these, what are called linear densities. Should be just air, okay? What you see is this line here that gets lost in here, another line on this side that gets lost. If you remember your cardiac anatomy, heart is surrounded by what? There's a membrane that has a name. Pericardium. Peri meaning around, cardium meaning heart, membrane around the heart. Pericardium. Okay, so the pericardium is normally right smack up against the heart. But in this case, here's the heart. Here's the border of the left ventricle of the heart, right ventricle of the heart here. Left ventricle of the heart border was here, and that looks okay. But the pericardium is way out here. Okay, so what is filling this space in here is air. Okay, so shouldn't be there. So you have that pericardial space where we normally have a little bit of fluid to lubricate the heart while it's beating. It's got air in here. So it's what's called a pneumopericardium. Pneumopericardium, air in the pericardium. Should there be air in the pericardium? No. I mean, somehow there was a communication between either lung or esophagus, which can contain some air, or trachea or bronchi, or something between that and the pericardium, and allowed air to leak into it. That's not good, because what happened, you get air in here, and that patient's heart can't beat as well. That's why they're in the hospital with all these electrodes and stuff, because there's heart function is very poor. Okay, good, thank you. All right. Ms. Meow. Again, another volunteer. This is not a radiograph. This is the first one we say, this is an image challenge, not, I'll probably show you some things that are also not radiographs. But okay, so you take a look at this guy, lying in the bed. Again, if you do a chest x-ray on him, you see all these electrodes, and you know he's not doing well. Okay, these are EKG electrodes. Okay, and got this black stripe here is to de-identify him. Doesn't help much, but you know, typical. And when you photograph patients for medical publication purposes, you would black their face out, parts of it. But what's odd looking about this person?
It looks like his blood is going to
Uh-huh.
up chest and
Yeah. Okay, he looks very bluish blood there. Yeah, and look at the very strict demarcation here. This is something called a superior vena cava syndrome. Something that blocked off the superior vena cava and backed the blood up to the upper part, the part that drains. So it'd be the head, the face, and the neck, and both arms, and parts of the chest. So it got engorged with this, you know, venous blood's deoxygenated, so it's like kind of a purple blue. But somehow, I don't know why this is, a blood clot or something, or maybe a tumor mass or something pressing on it. It can be even this, you can see this in people that have maybe had a particular anomaly of their arterial and venous system congenitally, and they go along for years and nothing happens until somehow something gets trapped against a bone or something like that, and it cuts off them. So anyway, lots of things can happen, but that's what this is. Okay, good, thank you. Time for a couple more here. Ooh, let's see. Oh, pictures on one page, names on another. Xiao Yu, Qi, Q-U-I, is that?
yeah.
Is the chest radiograph.
Is it a chest radiograph? Is there contrast?
Yeah.
She said, I think she said yes.
Yes.
Said yes. There is. We give, there are two kinds. We have venous contrast, intravenous contrast, or oral contrast. In this particular case, this is a tube containing oral contrast. It goes up like this, and then it goes into the person's nose and down to the back of the nasopharynx and into the esophagus. And the point of putting what's called a nasogastric tube is to control the contents of the stomach, okay, or put things into the stomach if you need to look at parts of the intestine and stomach with a radiograph. Most of the time you can just drink it. But in some people that are not very cooperative, this is a little kid, you can tell by the size of the radiograph, you get all the way down, all the way almost to the pelvis, part of the head. You know, what they wanted to look at the small bowel and stuff like that in this child. They put the nasogastric tube in and put the contrast in through the tube. Okay, well, it's supposed to be the end of the tube. There's ways you can test at the end of the tube, actually in the stomach. Have you done that? Just squirt some air into an NG tube and listen to the bubble?
On a mannequin, not a person.
Yeah. There's lots of ways you can check. And this is in the stomach, so that's good. And so here's the contrast they put into the stomach. Where's the stomach? Where's your stomach? Yeah, it's in the abdomen, right? Yeah, it's in the abdomen. Where's this kid's stomach? It's in his chest. Okay, is the stomach in the chest? No. How does the stomach get into the chest? It doesn't usually develop there. It can. But in most cases, it's the diaphragm is ruptured. Okay, that's the border between the abdomen and the chest cavity is the diaphragm. If there is diaphragmatic rupture or some kind of a congenital abnormality where there's an opening, stomach slide right up in the chest cavity. Kid may not even know this. Okay, good, thank you. Yes, Mr. Schaffer. Bringing up the rear in more ways than one. Let's see. I love it.
Oh, jeez.
Yeah.
Alright, so there's lack of, I guess, vasculature on the left side. Wait, this,
Wait, first tell me about
oh, is that
what it is.
Sir, is it the
Okay, it's a radiograph
Yeah.
of, and this is the same person, just different views of the same thing.
It's like an,
And what area of the body are you?
it's like an arm or a leg. It's really, I don't even know.
We have a patella in the arm.
Oh, no, that's
No, that's not
this is definitely the lower.
Upper, it's,
Yeah.
it's, you know, it's
This-
proximal lower extremity, otherwise
That's
known
your
as what
femur.
bone? Femur. Yeah, good.
Yeah, so that, so it's like, it has to be vasculature, right? It has to be a lot of.
Is there contrast?
Blood. I'm guessing, yeah, definitely, right? If you see,
Did you guess?
I mean, the radiograph doesn't look like that, so it has to be some kind
Well,
of.
they're the same person.
Oh, there's different legs. There's different legs, or is this like two radiographs of the same leg?
Two radiographs the same way. This is an AP and this is a lateral.
Oh, okay, got you. Okay, so this is.
So is there contrast? Did we inject intravenous contrast?
I'm leaning towards yes, but I'm not sure.
You're leaning to.
Yeah.
Anybody else leaning toward yes? Let's take a vote. Everybody want to support him? Aye, it's not- Everybody, okay, no.
No, it's not.
No.
Wow.
So if that's not contrast in blood vessels, and what is it? What's
It's gonna be more dense. It's gonna attenuate more. Right?
bone?
Is that really bone?
It's bone.
Jeez. That can't be good.
Let me show you a normal.
Oh, jeez.
That's bone. You remember? No, you wouldn't remember because you weren't here.
Oh, no.
Yeah. Remember the kid with the beta thalassemia? It's a different kid with beta thalassemia. It's marrow expansion. Wow. These are the trabeculi. Remember the trabeculi and spongy bone? You know, this kid's making marrow all through his skeleton, which is totally abnormal. Okay, so he's making bone marrow. This is an anemia, which body tries to compensate by making a whole bunch of extra red cells
Oh, so it's,
by expanding the marrow. So this is expansile marrow. Yes.
oh, and it's just,
Beta
it's like it's
thalassemia.
through.
Yeah.
Wow.
So that is. Okay. Well, thank you. And we will continue with Mr. Shen, who is, Mr. Shen, are you here? Okay. All right, we'll stop here and we will proceed with the next image challenge then after that. Hey, is it spring break yet? Fall next week. So, when does it start? Start now?
Friday at 7:30.
Something like that. So I don't think we have class next month.
Monday, yeah.
Great.